has an internal case. This is a female patient, 76 years old, and a native CT for exclusion of a duct stone urinary tract stone was carried out, and a dilated pancreatic duct was seen. No previous episode of pancreatitis, no pain, weight loss or diabetes was found, and Ms. Schäfer and Ms. Lehmann-Müller will support Mr. Otto in the procedure. Hello everybody, we look at the endoscopic ultrasound. The point is on the left and on the right. We are in the distal duodenum, just to give you an orientation. Here you see the superior mesenteric artery, and I would pull back to see the pancreatic head. Here is the processus ulcinatus, and often you don't see the duct so nicely. It's slightly dilated, and if you go back to the processus, then you get into an interesting part of the papilla. This is the pancreatic duct, it's dilated. And you see another lateral duct that is more prominent than usual. And if you go further to the left, you see the bile duct. Now I go to the right to find out why these two ducts are more prominent. There's nothing to be seen in the papilla. Well, there is some hyperechoic tissue, but no tumor visible where the two ducts join each other. But there is hyperechoic tissue, and you also see it in the Doppler. So sometimes you can use some water or irrigation fluid. So we bring the papilla to a swim, and you see more hyperechoic structures, and you see a long pedicle and then a hyperechoic area. So there is no diverticulum in this case, but now let's see the endoscopic view. So this is the endoscopic view of the endosonography, and here you find a lipoma that's bulging forward from the papilla. So here's a long pedicle, and then at 3 it goes down, and with this pedicle it approaches the papilla and covers it so you can't really see it. Our first theory was that the submucosal tumor creates a situation where the papilla is pulled down, and this traction causes a papillary stenosis. Here you see lipoma very nicely, but here we don't see any chronic pancreatitis. You see the ulcinate process again moving towards the left, the pancreatic duct, not the bile duct. And you see how the pancreatic duct from the ventral side goes to the dorsal side, so you excluded the divided pancreas. Now you see the body, and I follow the pancreatic duct towards the spleen, and you see dilated lateral ducts, also a dilated pancreatic duct. You see parenchyma is slightly, shows slight atrophies. Now you see it's 5 to 6 millimeters wide. Now you see the leonalis artery and vein, and if I turn, you see I move towards the tail. No nodules, no calcification, just the dilated duct with lateral branches. But something is changing here. So you see the dilated normal duct, then there is a brief distance where it narrows, and there is a strange wall structure, slightly stronger, and then the parenchyma becomes irregular. And on the bottom you see cystic parts, and after this short narrowing, the duct is wide again. in the tail, there seems to be an abnormality. We don't see a delimitated tumor, but it is a little blurred. So now let's show the Doppler for the vascularization and blood supply. There are some vessels, so it's not a necrosis, but it's perfused. Now I looked at the papilla behind the lipoma. There is nothing, but we had an endosonography of the patient before, because there was one moment when we saw the papilla and it looked like this. And we must say there was mucus. So this is an IPMN suspicion. That's why we had the dilation of the duct without any nodules. And we saw a solid structure in the pancreatic tail. So it is a lateral duct with involvement of the main duct. So it's a fish mouth type. We only have 5 to 6 millimeters of dilation, so it's not a high risk system. The fish mouth papilla was only visible once. Now I want to puncture for further diagnosis to clarify whether it's already a tumor, whether it's high grade, and to discuss with the surgeons how to operate. And we use an FNB needle for this. I briefly explain the needle to you. It is a microtech needle, the so-called trident needle. It has 2 additional features other needles don't have. It doesn't have the typical closure with needles, but this is a click closure system. You can lock it and click it, and it automatically clicks out again if you press it again. The second feature is that the tip of the needle is a multiple tip needle. In this case we have 3 tips, 1 long one and 2 shorter ones. That's why it's called trident. And this ensures optimum penetration of tissue and good harvesting of material. We use a duodenoscope again. I give the nurse a needle, and now I have to focus on the lesion again. Are there any questions up to this point? No, but we only have 1 minute left. Okay, yeah, I was a little late, so I go full force now and full speed. Well, do you have to puncture this finding if you saw the changes? And there is a fish mouth papilla. The main duct IPMN diagnosis is secured, and this is also securing the indication for surgery. Well, what's solid here is that these are nodules that are not classic nodules, and we carried out a very good MR, and in the MR we didn't see anything, only dilated lateral ducts. Now, I didn't want to distract you. Please puncture. Are we better than the MR? Yes, we are. But we need more information because the patient is very reserved. For her, it was a big surprise. She only had kidney stones, and now the serum is negative, and we really have to advise the patient well, and she wants us to do our best. The fish mouth papilla was only seen once and never again. So the question is whether with this short moment we can be relatively sure. Now here I do not want to puncture the vena lenalis, and this is an FNB needle. I push slowly with an opened alveolum lever. And here now you see the mandrill is pushed forward. In the endosonography image you can see it very nicely. Yeah, you see it on the top left very nicely. But don't get into the splenic artery or splenic vein. I prepare the needle by pulling down the closure. Could you please hold it that we're exactly in the tail before it branches off to the spleen. Pausing the splenic artery, there's quite a lot of alveoli. Now, it depends on how the patient is breathing. I took a 19G needle because I might want to use suction of liquid. Now I take the stiletto back and it's very white tissue. With the elastograph it was also very soft, and please hold it again. Well, we have limited control because of the breathing of the patient. It's not us shaking, it's the patient moving because of her breathing. Well, the problem is that with the variability of her breathing, I have a difficulty to set the scope properly. I do not want to puncture anything. Now it's better again. Sometimes it's good to just hold on. And here you see the large lesion. Now we move back to the spleen. That's exactly the problem, that I need a stable position. Okay, now, decisive attempt. Well, just go in. Well, Mr. Faiz. If we miss, that wouldn't be nice either, right? So the problem is coupling. But again, this is life, and you see, this is not a sham. This is slightly difficult. You get a beer too. Okay. I loaded the needle again and I tried to apply a little more pressure. But you see, I only push the wall of the stomach forward. Now, if it doesn't work now, I use a 22 needle because maybe in this position with a thicker needle, you can't enter. So I would reposition and perhaps you come back later after the ERCP. Otherwise, I've recorded. Yeah, good proposal, 22 needle. Maybe you show it to us tomorrow. Thank you very much.